In this video, we're going to look at precipitous birth and some of the complications associated with it. We should first define imminent labor, and imminent labor is delivery less than 3 hours after the onset of normal contractions. So basically, what we're looking at is a patient who has had the onset of normal, regular contractions or contractions that would indicate labor is going to progress, but birth has become imminent within 3 hours. So the patient says, my contractions started, they're a minute and a half in duration, they're lasting every about 2 or 3 minutes. And we arrive there less than 3 hours later, and they're presenting with things like bulging perineum, urge to push, feeling like they're going to have a bowel movement, presenting part or crowning of the baby. That would indicate that we have an imminent delivery that has started after about 3 hours or started less than 3 hours after the start of normal contractions. You can also consider applying some of the techniques we're talking about if the patient is progressing rapidly through the second stage of labor. So if the patient is not necessarily in what we would define as a precipitous birth, but we see that from the time the membranes are bulging or we see bulging in the perineum, the mom feels the urge to push or we start to see the baby coming, if that process is happening rapidly and we think that the patient is at risk of perineal tearing, you can put some of these things into practice. Precipitous birth occurs in around 0.1 to 3% of all births and is much more common in multips, although it can occur in premips. The reason we want to be cautious with precipitous birth is because there are a number of short-term complications that can occur. Postpartum hemorrhage is common due to uteroanatomy, so as the uterus has to work very hard in a short period of time, it can become exhausted, fatigued, or damaged, which may not allow it to contract properly. The other problem is that we can see perineal tearing, so we can see large tears of the internal external membranes of the vagina, tearing of the perineum. Both things can lead to fairly substantial postpartum hemorrhage. It's important to remember that postpartum hemorrhage is one of the leading risks of maternal death, so we want to be able to avoid that as much as possible. Outside of the short-term risks, we should be aware of some of the long-term consequences. So if we have perineal tearing or damage to the perineum, patients can be at risk of incontinence in the future, fistula formation, where there may be a communication between the vagina and the anus, or chronic peritoneal pain. So if we can, we want to avoid that through guarding of the perineum or creating safety for the perineum during birth. With that being said, let's walk through a few mechanisms that will help us prevent explosive birth and guard the perineum during precipitous labor.
So there are a couple things that we're going to want to assess for once we've determined that this might be a precipitous birth. So the first thing, obviously, we're asking about those contractions. When was the onset? When did the water break? And are we having frequent, strong contractions or regular contractions within 3 hours of an imminent delivery? So we're going to continue to ask mom questions around how imminent is the birth? Is there the urge to pare down? What are we looking at in terms of the mom's conviction that the baby is coming? Do they feel anything between their legs? We can also take a look to see if we have things like crowning of the head, we have bulging of the membranes, or bulging of the perineum. So these types of things are going to let us know that the patient is in imminent delivery. If the signs aren't as clear as they are here, one of the things that you want to be aware of is how quickly accelerating are those signs. So is the patient's urge to bear down or the conviction that the baby is coming or the bulging of the perineums, is it increasing rapidly, which is a good sign that this patient is headed towards an imminent delivery. So when we look at precipitous birth, there's a few things we need to consider. If the baby is coming too rapidly, the risk is of tearing of the outer and inner membranes, and we want to try and slow that down. So there are a few procedures that we want to put in place so that we can slow this birth down. One that we want to put in place is we want to encourage the mom to pant and not push. So instead of pushing with contractions, the uterus will still continue to contract. We would ask mom to continue to pant rather than push. Again, that will require a lot of communication. We likely want to express to the patient, listen, the birth is happening very quickly. We want to slow things down a little bit to prevent things like tearing. So instead of pushing with your contractions, I'd like you to just pant heavily. Again, that may require some coaching. You may want to have someone actually showing the patient what to do in those instances and reassuring them as they are doing it. A couple of other things that you can do to slow down this birth is put the mom in the anti-gravity position. So this is where you may want to have a number of towels to support this. Once we have our towels, we can communicate with mom and have her basically get into the bum up position, or we want to assist mom in getting into the bum up position. and placing those towels in a way that we are going to allow gravity to support the vagina being positioned in the air so that we're kind of working against gravity as this baby's trying to be delivered. Now, the other important thing that we can do to avoid perineal tearing and reduce the risk of tearing is provide perineal pressure. And there's a couple of ways in which we can provide perineal pressure. First is we can use our middle finger and the subsequent fingers to provide pressure on the perineum. So in this version, what you would do is you take the middle finger, you put inward pressure on the perineum, and then we're going to use our thumb and forefinger to pinch the membranes at the bottom part of the vagina. So what we're doing here is we're putting inward pressure on the perineum using our middle finger, and then our thumb and forefinger in this V positioning are putting some pressure in to support opening of the membranes, but prevent further tearing past the point of pressure. The other benefit of this is that we're going to put some superior pressure or upward pressure onto the baby's head, and this can help with delivery. So in this instance, again, I have my middle finger and subsequent fingers putting pressure in on the perineum, and then my thumb and forefinger are helping pinch the membranes open, but basically stop where we don't stop the membranes from tearing as we put that pressure in, and we get that inwards pressure to prevent tearing. The other mechanism that you can use, or the other way in which you can support this, is by using your palm to put pressure on the perineum. In this version, our palm would be pushing up on the perineum, and then we'd be doing the same thing with our thumb and forefinger, is we're going to put pressure in on the membranes. That's going to prevent tearing side to side here. And then our palm is putting this pressure upwards on the perineum to prevent perineal tearing. Again, this is going to help support movement of the baby's head up. So we actually should get some pressure up on the baby's head, which can support delivery. And in both cases, you're taking the opposing hand and you're going to put gentle pressure on the vertex of the baby's head. And this is going to just prevent, again, explosive birth. We're not pushing the baby back in. Again, it's just gentle pressure with the opposing hand, whatever version of perineal pressure you're using. The use of perineal pressure is also beneficial for long-term outcomes. So putting that pressure onto the perineum and preventing tearing, we're going to help decrease the chance of fecal incontinence, of anal fistula forming or a fistula between the vagina or the anus. So we're looking at some fairly significant long-term outcomes or positive long-term outcomes just by putting this type of pressure on. So again, we're doing this in cases where the birth is imminent. So we see bulging perineum, we see the baby head crowning, we see that the mom has the urge to push, and those things are happening within 3 hours of the onset of normal contractions. So these things don't necessarily need to be put into place if the mom is not having a precipitous labor. So again, that onset of normal contractions or regular contractions within 3 hours of imminent delivery. Where you may want to consider this, though, is if we see the second stage of labor progressing really rapidly. So maybe the contractions were longer than 3 hours, we saw onset greater than 3 hours, but the time we've gone from the head crowning to expulsion of the baby is looking like it's happening very rapidly. These are still beneficial maneuvers that we can put in place to attempt to basically guard the perineum or create safety for the membranes in the perineum for mom. Once the head is delivered, this gives us the opportunity to assess the baby. Obviously, we should have our partner setting up a resuscitation station if required. And this also gives us the opportunity to look for things like meconium or secretions in the baby's mouth. Remember, we're not routinely suctioning the newborn at this point. Even if there is some meconium, if it doesn't appear to be obstructing the airway, something as simple as taking a towel and wiping the face is enough. If we don't see any secretions or anything in the airway, the mouth or nose that would require to be wiped away, we can just leave things as they are. There's no need to get too hands-on with the baby unless absolutely necessary. Remember, as the head is delivered, this offers the chance for restitution of the shoulders. So we can wait, about 1 or 2 minutes for the shoulders to turn, and this will support delivery of the rest of the baby.
Before we conclude this presentation, let's recap some of the things that we've talked about. Outside of our normal questions for delivery, one of the first things we want to do is determine if this birth is precipitous. Has imminent labor started within 3 hours of the onset of contractions? If so, we want to place mom in the anti-gravity position, so bum up to allow gravity to support us in slowing down this birth. During this time, we should be encouraging mom to pant rather than push with contractions. Next, what we want to do is guard the perineum using one of the two techniques we talked about. So in this case, you might be using your middle finger and subsequent fingers to put pressure on the perineum, while your thumb and index fingers are in a V shape about 12 centimeters apart, putting pressure on the membranes. As we talked about, this should help support delivery of the head as well. Alternatively, you may be using your palm to apply pressure on the perineum, while again your thumb and index finger are about 12 centimeters apart in a V shape, applying pressure to the membranes. That will prevent both membrane tearing and peritoneal tearing, as well as supporting help delivery of the head of the baby. Finally, the last thing we want to do is use our non-dominant hand to apply gentle pressure on the vertex of the baby's head. This will slow down delivery and hopefully prevent explosive delivery of the baby. Thank you for watching this video on precipitous labor and some of the techniques we can use to manage it.